Hi, my name is Reid Prichard, and I'm a PhD student at Liberty University studying under Dr. Wayne Strasser. Today I'm going to tell you about a novel method to diminish the spread of airborne contagion such as COVID-19 in a hospital room. First, for some background, the human eye can see particles as small as 50 micrometers. COVID-19 can be transmitted by particles 1/10 that size. That's the difference between a marble and a grain of sand. To date, 10% of the US population has tested positive for COVID-19. Over 500,000 deaths here have been attributed to the disease. Even before the COVID-19 pandemic, the airborne diseases of pneumonia and the flu ranked the 9th leading cause of death in the US at 50,000 deaths annually. It is clearly crucial to develop tools to combat the spread of airborne contagion. Even a slight reduction to these numbers would mean thousands of lives saved annually. Amidst the onslaught of COVID-19 in New York, a doctor at New York Presbyterian Hospital devised an apparatus he called Felix 1. Felix 1 uses high-velocity nasal insufflation, or HV&I cannula, to administer high-velocity warmed and moistened air to a patient's nostrils. This is a mild form of ventilation, which is important when treating respiratory diseases such as COVID-19. Typically, these HV&I cannula would be used with a surgical mask to capture airborne contagion. However, surgical masks have several drawbacks. First, as I'm sure you are aware, they can be uncomfortable because of the heat and the humidity that they trap up against your face, as well as the physical contact on your skin. Additionally, leakage around the periphery of the mask dramatically reduces its effectiveness. Finally, these masks cannot be reused, which can cause recurring expense and can be problematic in the issue of a shortage as we saw in COVID-19. To address these issues, Felix 1 replaces the surgical mask with a plastic face mask which is connected to a suction line. This suction constantly pulls fresh, cool air past a patient's face, improving comfort, and it is hoped that the active evacuation of particles via suction would improve effectiveness. The objective of this study was to evaluate the effectiveness of Felix 1 at capturing exhaled particles. We performed a computational fluid dynamics study using ANSYS Fluent version 2020 R2. As shown below, we modeled an entire hospital room containing 6 subjects. We modeled 2 patients denoted P1 and P2 who were equipped with the Felix 1 apparatus, and 4 caregivers, CG1A, CG1B, CG2A, and CG2B, who were equipped with no mask. Shown on the bottom right, our realistic airway models created with the help of medical imagery aid the accuracy of turbulence and velocity characteristics leaving the nose and the mouth, which is important because it influences the trajectory of the particle as it goes through the room. Also, the proportion of flow through the nose and the mouth relatively, and the influence of the HV&I cannula on particles in the airway. We used a discrete phase model to track 1,500 inert particle injections. We gathered transient data of steady particle tracking. So every few time steps, we performed steady particle tracking for 10 minutes of particle time, and then we averaged that data performed every few time steps over 7 seconds of flow time to make our conclusions. We used the SST model to model turbulence. The boundary conditions are another important part of our model, in particular, the airway boundary conditions. Not only did we use realistic physical geometry to represent the airways, we used realistic breathing curve shapes. As you can see on the right, the breathing curves featured asymmetric inhalation and exhalation. So the portion of the curve above the horizontal axis is different from the portion below. It's not a mirror image. Second, we used 3 unique breathing rates. You can see that the blue curve represents the fast breathing rate, the red curve represents the slow breathing rate, and the gray curve is in between. Lastly, we randomized the inhalation and exhalation amplitude per breath cycle. When you breathe, you don't breathe exactly the same breath every single time, so this randomization gives some variation that makes it more realistic. Our HV&I cannula injected air at 40 liters per minute, which comes out to 25 meters per second. The mask evacuated air at 30 liters per minute, which is 1.8 meters per second on its outlet, and our room ventilation used a representative value of 6 air changes per hour. So the air in the room was turned over 6 times per hour. This came out to 0.06 meters per second. The wall vents were set to pressure outlets at 0 pascals. Here is an example of our mesh. We used a hexahedral polyhedral mesh of over 130 million elements, and you can see here that we utilized very fine elements in the airway, which we grew moving away from the face. This shows the blocking scheme we employed. While our final mesh differed from this a little bit in that its sizing functions were slightly different and that we converted the tetrahedra seen here into polyhedra, this shows that we heavily leveraged the hexahedral elements in the bulk of the room wherever we could. Not only does this reduce diffusiveness, it allows us to use fewer elements, bringing our computational costs down. Because of the size of our model at 130 million mesh elements and the length of time we needed to simulate to reach quasi-steady state, it was important to optimize our hardware scaling to keep our costs low. This presents a multi-objective optimization problem with the dual objectives of simulation speed and simulation cost. We performed testing on a range of machine counts from 1 to 36 of the Azure HBV2 machine, which has 120 cores per machine. We created a normalized cost metric that is dollars per million cells per million iterations. This metric is completely independent of simulation speed, so doubling this metric means the project will cost twice as much, and say halving it means the project will cost half as much. We ended up choosing 18 machines because of its balance between cost and speed. The plot below shows our alternatives, and you can see that 18 machines is much faster than 3 machines, which was our next best alternative, while it is only 17% more costly. So you can see that its red data point is much lower than those to the left of it, whereas its blue data point is not terribly higher. We monitored a wide range of variables to assess convergence, and ultimately we relied on our particle data to inform convergence. You can see on the right 2 metrics we considered. One was the number of particles captured by P1's mask, and the second was the number of particles that ended in CG2A's airway. You can see that the mask convergence was converged long before the end of our study, while CG2A airway particles were still converging. We decided this was acceptable because these numbers were decreasing, which would mean that any error in our results would be on the conservative side by underestimating Felix 1's effectiveness. Though I will be focusing on summary statistics, we gathered particle data on all surfaces, including caregiver phones. We found that the mask captured 95.8% of particle mass, compared to a much lesser 88.8% for a surgical mask. Of those that escaped the mask, few reached the caregiver's airways, and as you can see on the bottom right, most of those that reached the caregiver's airways were smaller than that 5 micron limit of the smallest particle that can transmit COVID-19. In total, we found that only 24 parts per billion were inhaled by the caregivers. Looking forward with this research, we would like to implement a number of numerical or physics changes. First importance is conducting a mesh-independent study, and we would also like to produce results with transient and coupled particle tracking. Additionally, evaporation effects can be very interesting because of their effect on particle lifespan. Lastly, the heat plume from the human body has been shown to affect particle trajectories. We are also interested in studying additional scenarios, such as the patient coughing, sneezing, or using a different cannula or suction flow rate. The Felix 1 mask showed a significant improvement over a cloth surgical mask, only allowing half the particle mass to escape. Of the mass that escaped, only a tiny fraction reached the caregivers, posing little threat to them. Even past the conclusion of the current pandemic, it will be necessary to diminish the spread of airborne contagion. So we are excited that we are able to give hospitals the information they need to equip them with new tools to fight contagion. Thank you.